All right. I am proud to introduce our next clinician, Dr. Mellanie Gillingham. Dr. Gillingham's research in the Department of Molecular and Medical Genetics has focused on various novel therapies for fatty acid oxidation disorders. For 20 years, Dr. Gillingham and her colleagues have conducted clinical trials in subjects with disorders in the fatty acid oxidation pathway. She has examined the effects of medium-chain triglycerides, MCT, supplements prior to exercise and has evaluated the effects of increased in dietary protein prior to exercise. I lost my spot. Protein on metabolic control and energy balance in people with LCHAD, CPT2, and VLCAD deficiencies. In 2014, a group of FAO researchers under the leadership of Dr. Jerry Bockley founded the International Network for Fatty Acid Oxidation Research and Management, INFORM, an international group working for the advancement of medical and nutrition therapies for fatty acid oxidation disorders. Dr. Gillingham participates on the organizing committee of INFORM. Most recently, Dr. Bockley and Gillingham completed a randomized trial in examining the effects of an odd-chain fatty acid supplement, triheptanoin, on myopathy and cardiac function of patients with long-chain fatty acid oxidation disorders. Dr. Gillingham has also conducted a series of studies examining the etiology of retinopathy in LCHAD and the role of diet in the progression of vision loss. Dr. Gillingham has been a meaningful clinician in my life. I not only appreciate her brilliance and commitment to our FAOD community, but her willingness to listen and ask questions. Additionally, much like the processes that she researches, she breaks down things in an easily digestible way that brings ease to this journey. Thank you, Dr. Gillingham, for joining us today and sharing with us about your most recent research with ketones.
Thank you, Annika. That was a really nice introduction. I'm thrilled to be here. It's great to see all of you and lots of friendly faces. I'm going to be talking today about oral ketone supplements. And I think I'm going to say next slide. Okay. So I'm going to spend about a first third of the talk really talking about what are ketones and why are we doing this? And then I'll dive into a little bit of data of a couple of different published papers, as well as a study that we recently completed. So what are ketones? I've drawn the chemical structures here, which aren't important, but the names are something you probably have heard. Beta-hydroxybutyrate and acetoacetate are the primary ketones that circulate in our blood, and acetone is also a ketone, but the main ones are beta-hydroxybutyrate, which we'll spend most of the time talking about. And what do ketones do? They are an alternative form of energy, just like glucose. Next slide. So how are ketones made? This is a really important point. So in people, we mobilize fatty acids from our adipose tissue. They travel in our blood to our liver, and then we use fatty acid oxidation to break those fats into acetyl-CoA, and the acetyl-CoA in the liver makes ketones and puts it out into the bloodstream. So it's the process of fatty acid oxidation that normally makes ketones in the blood. Starting to sound familiar? So that's probably not something that patients with fatty acid oxidation disorders can do. The ketones in the blood then circulate and they provide energy specifically to the brain, the heart, and the skeletal muscle. Those are the tissues that really like to use ketones. And the process of breaking down a ketone and converting it to energy does not use the fatty acid oxidation pathway. So all patients with fatty acid oxidation disorders can use ketones, but we can't make them in the liver through the process of fatty acid oxidation. Okay, next slide. So when do people make ketones? Well, my slides got a little twisted there. It's supposed to be fasting with a G there. So when we fast and we mobilize those fatty acids from adipose tissue, that's when we make ketones. So when you go for a long period of time fasting, your glucose goes down and your insulin goes down. That's a really important component. And that causes the release of those fatty acids from adipose tissue, and your liver starts generating ketones. So in people, ketones rise after a period of fasting, but not in patients with fatty acid oxidation disorders. So in normal people, ketones rise, but in patients with fatty acid oxidation disorders, the ketones do not go up because you can't convert the fats to ketones in the liver. Okay, next slide. What are some other times in which ketones might be made? People might be making ketones. Exercise, in particular, moderate intensity exercise. So this was a study that looked at the change in ketones. We're going to look at the red bars in the middle. The top graph is after someone was swimming. And you can see that there was a little bit of rise from before swimming to after swimming in the ketones in the top bar. In the middle bar, it's cycling. So that long, moderate intensity ride on a bicycle, and you can see a big rise in ketones. So that really raises your ketones. And then high intensity, if you're just doing spurts, high intensity exercise, the ketones do not go up. So moderate intensity exercise and fasting is when ketones typically rise in blood in people, not in patients with fatty acid oxidation disorders. Okay, next slide. Another way you could make ketones, one that you probably have all heard about, is a ketogenic diet. And that's, in fact, the purpose of a ketogenic diet. A ketogenic diet is where we take carbs away and we eat a lot of fat, and we use that fat to make ketones. I'm going to have you hit just the space bar. There should be a next, hit a next for me, please. There we go. Yeah, oh, back. Ketogenic diet is not appropriate for fatty acid oxidation disorders, but that is why people eat it, is to make ketones. Okay, so this is not a good idea for anyone with a fatty acid oxidation disorder. And what it's doing is it's trying to use fat and convert it to ketones in the liver. That's the point of that particular diet, not for this population. But I'm just trying to illustrate when you might have elevated ketones in your blood in someone who does not have a fatty acid oxidation disorder. Okay, next slide. So in general, patients with fatty acid oxidation disorders are what we call hypoketotic, or they have low ketones. So they don't make ketones like someone else would. They mobilize fatty acids from adipose tissue, great, they go to the liver, but because of the block in the fatty acid oxidation pathway, they can't make ketones. So I think of ketones as the end product of fatty acid oxidation in the liver. The last thing, the product that you get at the very end, is a ketone. Okay, next slide. So because of that, ketone supplementation could work for all long-chain fat oxidation disorders. It could work for long-chain disorders. It could work for medium-chain disorders. It could work for short-chain disorders. It can work for multiple CoA. It can work for MAD, GA2. It can work for all of them. So how much energy do ketones provide? Well, when we take a long chain fat and we break it into fat to acetyl-CoA, it makes 8 acetyl-CoA, or it makes, you take 2 of those to make a beta-hydroxybutyrate, so it makes 4 ketones. If you have a medium chain fat, it makes 2 ketones. If you have a short chain fat, it's going to make 1 ketone. But glucose and ketones both make 2 acetyl-CoA, so they basically have the same ability to provide energy, both glucose and ketones. Can I hit next? Yeah, so that doesn't work. So we can't do long chain fat oxidation for long chain fatty acid oxidation disorders. So that would be CPT2, VLCAD, LCHAD, trifunctional protein deficiency. We can't convert medium chain fats to acetyl-CoA in MCAD deficiency. Next. And then for SCAD or SCHAD, we can't use short chains, but everyone can use glucose and ketones. So ketones would be a universal supplement energy substrate for all fatty acid oxidation disorders. It's the end product of fatty acid oxidation in the liver. Okay, next slide. So how would you take supplemental ketones? If we can't make ketones, perhaps we could take a supplement and replace those ketones that we would normally make. And because the liver can't do it, how would we do that? Well, this is an interesting review that there's 4 different types of ways you can take ketones. There's pros and cons of all the different forms of ketone supplements. I'm not going to spend much time with the first one. It's an alcohol derivative of a ketone. The disadvantage is it doesn't taste very good. It has a very bitter taste. It does cause some GI distress, similar to MCT, and it can cause a little bit of alcohol intoxication. And because of that, it's sort of been ditched as a method of ketone supplementation. MCT, we've talked about at this conference multiple different times. So we don't use I'm not going to talk about MCT today. MCT is a way for patients with long chain fatty acid oxidation disorders to make ketones. They can use that MCT in the liver and make ketones, but it doesn't work for MCAD, SCAD, MADD. So I'm going to focus on the bottom 2. So you can see there's one that's the ketone salts. That's been by far the one that's been tried the most. So it's got a salt, a sodium attached to a ketone, a hydroxybutyrate, and you mix it in water and it has a salty taste. It tastes salty. And so the disadvantages are it can cause a lot of sodium overload, too much salt if you take a lot of ketone salts. It can also cause a little bit of GI distress or a lot of GI distress with this really high salt load. But that's been the one that's been used the most. The other one I'm going to talk a little bit about is a ketone ester. So people have been trying to modify ketones and esterify them, attach them to a glycerol backbone so they look a little bit like a triglyceride, except for when you take those things off the backbone, it's a ketone. So it's a ketone ester. And there are a couple of companies who've been working on making these ketone esters. So the disadvantages of these ketone esters is it has a very bitter taste, kind of like the ketone alcohol derivative, and it can cause some GI upset. So we're really going to look at the sodium, the salt form of a ketone supplement, and the ester form of a ketone supplement. And again, the advantage of this product, of this type of approach, is that it could be for all fatty acid oxidation disorders. All right, next slide. So I want to just spend a little bit of time going through 2 papers, one that used the sodium, the ketone salt, it's a review paper, and then one that looked at the ketone ester. So the first one looked at the safety of using a sodium ketone supplement, in this case hydroxybutyrate, in multiple CoA dehydrogenase deficiency, or MADD. And it reviewed the literature for everyone who had tried this approach for patients with MADD. And it actually really accumulated quite a few patients for this particular review. So they had 16 patients who had been on ketone supplements and had seen some clinical improvement. They had 3 patients who had tried ketone supplements, but they weren't sure if it was an improvement or not. And then 4 patients who had tried sodium hydroxybutyrate and did not see a clinical improvement. And in this table, you can see sort of the distribution. At the time of the publication, the current age was 13 years, 3 years, and about 13 years in the 3 different groups. MADD, as you know, is a pretty severe disease, so a few patients had unfortunately passed away. The age at onset in which they were diagnosed with MADD was 3 months, 3 days, 3 months, so very young. And so let's go to the next slide and look a little bit at what happened. So what kind of clinical improvements have been reported with ketone supplementation? In this bar, this bar graph gives you the number of patients, and in the gray, it's those who had clinical improvement. The kind of whitish color is questionable, and then the very white is no clinical improvement. So let's start with just the cardiomyopathy at the beginning. So there were 3 patients in this group who had cardiomyopathy. And when they took the sodium hydroxybutyrate, all 3 of them had improvements in cardiac function. There is a lot of research actually going on right now in the cardiac world looking at ketone supplementation in heart failure patients that don't have a fatty acid oxidation disorder. So this is an area where I think ketones have demonstrated they have an impact. They improve cardiac function. The next bar is leukodystrophy. That's white matter changes in the brain. There were 4 patients that had clinical improvement and 1 that they weren't sure if it was an improvement when they started on the ketone supplement. So they were looking at the white matter of the brain before they started the ketone supplement and then looking at it again after, and they saw some improvement. Of the liver symptoms, about 6 patients had an improvement. 1 was not sure, was questionable. The next bar is really interesting. Most of the patients had muscle symptoms. This is something that I think many of you can relate to. Fatigue, rhabdo, those types of symptoms, and 14 of them had improvement in muscle symptoms. 2 were not sure, 2 saw no clinical improvement, but the majority felt that their muscles were better when they were on ketone supplements. There were some respiratory issues, and some of them improved with that. The thing it did not improve, there was no improvement on ketone supplements in neuropathy, and it didn't seem to prevent some of the symptoms of MADD. So in general, it felt like this study was pointing to an improvement in cardiac function, in liver symptoms, and muscle symptoms. To me, was most impressive in this group of patients that were taking the sodium hydroxybutyrate. Next slide, please. So how long were these patients taking this supplement? The blue line shows what percentage of patients were taking it for how long. And if you follow that out to the very end, some of the patients were taking sodium hydroxybutyrate for out to 11 years. So a long period of time they had been taking this ketone supplement. Those with no clinical improvement obviously stopped earlier, but some of them tried to stay on it for up to 6 years. The ones that were questionable stopped fairly early. So we have data in patients taking sodium hydroxybutyrate out to 11 years, which is a long time. And so we have some good data on how long people have taken it. It doesn't seem like it helped immediately. It took a little while before they saw much of a difference on the ketone supplement. Okay, next slide. What is the dose? How often do you have to drink this salty ketone supplement? Well, how much of it? So I want to just hone in on the red box that I circled here. So the doses vary. The maximum dose was usually 400 milligrams per kilogram. It's hard to get your head around what that might be, but I envision a pretty mounding tablespoon or more of a salty thing mixed with water. So it's not small, it's a lot. And they typically took it 4 times a day. So they would drink this salty ketone supplement 4 different times during the day. Okay, next slide. So what about the downsides? There has to be some downsides to drinking all this sodium ketones. So I'm just going to talk a little bit about the adverse effects that were reported in this study. So when we talk about adverse effects, I just want to make a little bit of a caveat. They're collecting anything bad that happened while they were taking the study. We don't know if that bad thing that happened is related to the salt hydroxybutyrate, but we're just collecting the information. So it's not necessarily related. It's not necessarily not related, but it's just the bad things that happened while people were taking the sodium hydroxybutyrate. As I mentioned before, MADD is a very severe disease, and there were several patients that unfortunately passed away. One patient had a pretty prolonged hospital stay. Abdominal pain, constipation, could be parts of the disease, but could be because we're drinking a lot of salt ketone supplements. The dehydration is the thing that stood out to me. That much salt could definitely cause dehydration. That one's probably related to the salt load of this ketone supplement. It can cause some diarrhea and some nausea and vomiting. So again, most of the adverse events were focused on GI symptoms. And we said in the beginning that these sodium ketone salts can have some GI related symptoms. Okay, next slide. So now I'm going to move on to a study that was done with ketone esters. So this is a different type of ketone, and the ketone is attached to a glycerol backbone, so it's somewhat like a triglyceride. And the way this product is actually available on the market, you can buy it. And because I'm adventurous and I like to try stuff, I've ordered it and tried it. It comes in little vials. It look like a 5-hour shot, but it's a ketone. And they try to put a raspberry flavor in it. I'm not sure I'd think that it's raspberry. In fact, it tastes pretty yucky. I didn't throw up, but it doesn't taste good. But they try to coat it with this raspberry stuff, but it is available. You can buy it on the market. What this study did, this was some investigators in Amsterdam in the Netherlands, and they did a really nice study where they took 5 patients with VLCAD, and these patients did exercise with the ketone ester or with carbohydrate. So there was one time they exercised with carbohydrate plus ketone esters and one with just the carbohydrate. And they were looking for differences in their performance, their exercise performance. And I don't know if you've ever been to the Netherlands, but everybody bikes there. So their exercise was a bicycle. So they were on a stationary bicycle when they did this exercise. I'll start by pointing out to that panel B, which is the GI upsets. So they had a couple of patients who took their ketone ester drink who did throw up, and they had a little bit of nausea and some GI upset. So it definitely causes the GI upset as advertised earlier. But how did they do with exercise? The bottom panels, C, D, E, and F, let's focus on those. So when they looked at creatine kinase, so that CK level, before and after they bicycled with the ketones and the esters. So in this case, the ketones are in the red and the carbohydrates alone are in blue. And the patients did a crossover. So they did both exercises. And there was no difference in CKs. So the ketones did not lower the CKs, but they didn't raise the CKs. When they asked the patients, how hard do you think that exercise was? That's a Borg scale. And you can say, well, it's very light, or I'm working really, really hard. And the higher number means you're working harder. And there was no difference. The patients perceived the work that they did on the treadmill or the bike the same. So they had the similar exertion. There was no difference in heart rate. The one thing they did see was a little bit of a lower respiratory exchange ratio. So what does that mean? The respiratory exchange ratio tells you whether you're burning sugar or whether you might be burning the ketones. So the lower number suggests that they were using the ketones during that bout of exercise. So some not big changes in exercise, but maybe shift in using the ketones while they were exercising. Next slide, please. Okay, a little bit more data. So again, these tables are set up the same way. The red is the ketone plus carbs. The blue is the carbs alone. So what happened to the blood ketone levels? So that's A. Well, when you took the ketones went way up, which is great. That means that you took the ketones and it raised the blood ketone levels. So that's good. As a result, the glucose was a little bit lower. The lactate at the end of the exercise on D was a little bit lower. And one of the things on the bottom panel I want to point out is that it lowered the acylcarnitine. So it suppressed the fat oxidation and it lowered the acylcarnitines in blood when they had the ketones on board. And that's a known effect of ketones. Ketones suppress mobilization of fat from adipose tissue, and it suppresses the liver's fat oxidation. So they had lower free fatty acids and lower long chain acylcarnitines. They had slightly higher acetylcarnitine, the short chain one. So suggesting maybe a little bit more energy was available when they had the ketones. So this was a positive response. It suppressed the long chain fat oxidation and it looked like it raised the energy through the C2 carnitine a little bit. Okay, next slide. So now go to our study. We were approached by Nestle to test a new ketone beverage product. And so that's what we did. And that's what I'm going to share with you. I literally was running the assays in the lab on last Friday, I think. So these slides are hot off the press. I have shown them to no one else so far. So you're the first ones to look at it. We did a similar study. We did a randomized crossover study that was blinded. So patients came in and they got either the ketone beverage or they got a control beverage, which was maltodextrin, which is basically sugar. And then 48 hours later, they came back and they repeated the treadmill and the exercise and they did the other beverage. And until I went into the lab to run the blood samples, we didn't know which exercise was which, maltodextrin or ketones. Okay, next slide, please. So what did it look like? This is the packets that we got. Could you hit next, please? There we go. So what's different about this product? I mentioned before that the sodium, the salt, connected to hydroxybutyrate causes that salt overload, too much salt. So what Nestle's product is that it used different salts. So it's some sodium, some magnesium, and some calcium. So it uses different salts in the ketone beverage. And it also did something else. Most of the time when you chemically make hydroxybutyrate, you get something called D and L. You get a right hand and a left hand molecule. And most of the time, the left hand, the L, we just pee out in our urine and we don't really use it for energy. We use the D. So this one includes just the D. So it only has the D and it has these different salts. So the idea was maybe we're making the ketone supplement a little bit better. They added a little bit of lemon lime flavor and a little bit of stevia to make it sweeter. To me, it tasted a lot better than the raspberry 5-hour energy shot. It tasted like a really salty Gatorade to me. And it didn't upset my stomach. So we all tested, all my lab, we tested it to see what it tasted like. And it has a slight, like I said, very slight lemon lime flavor. I'd probably recommend they up the stevia just a little bit because it was not very sweet, but it was very tolerable as a beverage. And all of the people in our study tolerated it just fine. Okay, next slide. So who participated? We had 5 adult patients. 2 had CPT2, 2 had LCHAD, and 1 had VLCAD. And they were diagnosed by acylcarnitines and mutation analysis. Their average age was 33, so ranged in age from 24 to 50, with 3 males and 2 females. Okay, next slide, please. So what did they do? They came to Portland, and in the morning, they stayed at a hotel, and in the morning they came to the hospital, and we got a fasting blood sample. So that's going to be our baseline blood sample. We measured body composition, and then we fed them breakfast. This was the closest picture I could get, but we had some cornmeal pancakes with berries and some yogurt. So it was a pretty balanced breakfast scaled for their energy needs. And then they sort of rested in the clinic for about 3 hours, and we would have them drink the ketone beverage, and we got a blood sample right before they drank it, and then about half hour after they drank the beverage. We use a treadmill. In the US, we typically use treadmills for our exercise testing. So we had leads on their chest so we could watch their heart rate, and it fitted them with a mask and got them all set for the treadmill. They walked on a treadmill for about 45 minutes, and then we got a blood sample afterwards. They had lunch. They filled out a few questionnaires like how was their stomach? Did they feel nauseous or anything like that? And then they would go back to their hotel. And then 48 hours later, they came back and repeated this same process. And I didn't know what beverage, whether it was maltodextrin or ketone at the time until after the study was done. Okay, next slide. So how did they tolerate it? Did it cause a lot of GI distress? In my slides, you're going to see the maltodextrin is always in kind of a yellow color and the ketones are in blue. So the number of people that complained of abdominal discomfort, decreased appetite, gastric reflux, nausea, diarrhea, or headache was definitely higher in the ketone beverage. About 3 patients out of the 5 complained of some of those symptoms at some time. However, when we asked them how severe that was, it was really on the mild side. So we gave them a scale of no symptom 0 or 10, really, really bad gastric reflux, for instance, and everybody picked about a 3 or 4. So it did cause some mild GI distress, but it seemed like it was fairly well tolerated and it was not very severe GI distress. Okay, next slide. How'd they do during the exercise? So again, we're looking on this slide. If you look on the volume of oxygen consumed, that's every 10 minutes during a 45-minute treadmill. Basically, we've got it baseline and then in 10-minute intervals. And you can see the amount of oxygen they used, which is how hard they were working, was the same for both the maltodextrin and the ketone. So that did not change. And when we asked them, how hard do you feel like you're working? Is it really hard exercise or is it a moderate? That was also the same. So they did the same amount of work, whether they took the maltodextrin or whether they took the ketones. Okay, next slide. What about heart rate? I was hoping the heart rate was going to be lower, but that's not what we saw. The heart rate was exactly the same between the two. I have published in the past that MCT lowers heart rate for the same work, but we did not see that with the ketones. So the amount of work and the amount the heart had to work was the same, whether they took maltodextrin or ketones. Okay, next one. How about substrate oxidation? If you'll recall, when I talked about the Netherlands study, they had a slightly lower RER. They were burning more ketones. We actually did not see a significant difference. The blue line's a little bit lower in the beginning, but statistically, those two lines are basically the same. So we did not see a big shift in substrate oxidation with our ketone beverage. Okay, next slide. How about CK? We didn't see a difference in CK. So CK, again, I guess I should have explained. All of these are those 5 blood points I talked about. So baseline was in the morning before they had it. The next dot is the blood sample right before they drank the beverage. So it's really those last 3 dots that you would expect to see the change at the pre-exercise, post-exercise, and recovery blood sample. But we didn't really see any difference. There's a little bit up in that pre-exercise sample, but statistically, those lines are basically the same. Next slide, please. Blood glucose, again, when you take maltodextrin, a few people had glucose go up. We were drinking glucose, so that doesn't seem so surprising, but statistically, again, there wasn't much of a difference. So they were the same. Next slide. What about the fatty acid oxidation? It did lower, it suppressed the long chain acylcarnitine. So when you look at C14, and you compare the blue line to the orange line, you can see that C14 with the ketone beverage did not rise, but with maltodextrin, it did. So they were increasing fat oxidation and trying to make ketones and making acylcarnitines instead when they took the maltodextrin, and when they took the ketones, that fat oxidation was suppressed. Both C14-1 on the left and C16-1 on the right. So it really suppressed the fat oxidation in the acylcarnitine profiles. Next slide, please. Did it increase the ketones? So this was the last assay I just ran. And yes, when they drank the ketone beverage, we raised the ketones to about 400 micromolar. It's similar to what you get with a dose of MCT. MCT might raise it a little bit higher, but we raised the ketones. The blood ketones went up. So that's good to know. We were able to raise the blood ketones. Next slide, please. And it suppressed that adipose, that release of fatty acids from the adipose tissue. So we looked at the non-esterified free fatty acids or free fatty acids, and it was lower in the ketones. So the way that ketones seem to work is they suppress the lipolysis from your adipose tissue. And so it lowers how much fat is going to the liver, and therefore lowers how much the liver is trying to do fat oxidation and making acylcarnitines instead in the case of a fatty acid oxidation disorder. Okay, next slide. So the conclusions of our little trial that we did is the ketone beverage was really well tolerated. We gave a pretty small dose, and with that small dose and an equivalent comparator, maltodextrin, we didn't see big shifts in exercise ability. So the heart rate was the same, the substrate oxidation was the same, the CKs were the same. We raised ketones for sure, and we suppressed fat oxidation. So we suppressed those free fatty acids and we lowered those acylcarnitines in blood. So those were the big changes that we saw in our 5-patient study. Again, the dose was a little bit small. We could probably go up on the dose, but we did see some biochemical changes in fat oxidation. Next slide. So just to finish up with a couple of points, there is a lot of research going on right now, not in the fatty acid oxidation world, but in science in general on ketone supplements. As I mentioned, there's a number of groups that are working on ketone supplements with heart failure. People are interested in ketone supplements with Alzheimer's and dementia. So there's a bunch of work working on ketone supplements as a treatment option in other parts of science. What I think this means is that there's going to be people developing better ketone supplements that are less GI stressful and are more well tolerated for general diseases that we can then use in patients with fatty acid oxidation disorders. So I think this is a hot area of research that's going to be continuing. Ketones do a lot of different things. There's people looking at it for lowering oxidative stress, cardiac remodeling, decreasing inflammation. So ketones are going to be in the future, in the next decade, a lot of research is happening in this area. Okay, last slide. So ketone supplements, the kind of sum up what I've talked about It's a potential therapy for all fatty acid oxidation disorders: long chain, medium chain, short chain, MADD. The ketone salts can cause a sodium overload. There's no doubt that taking that much sodium can cause dehydration and cause a sodium overload. Ketone esters have their own issues with side effects. It gets all around the salt issue, but it does have some GI side effects as well. I think they're going to be not only this product, but other products that are going to be developed that are better ketone supplements, that are better tolerated, that taste better and cause less GI substrate GI issues. And I think there's a growing interest in ketone supplements. They've become very popular with athletes. They improve athletic performance in some cases. And there's a growing body of evidence in neurological diseases and heart failure. So I think this is an area that's really going to grow over the next 5 or 10 years. So with that, I will stop, and I'd be happy to try to address any questions. So thank you very much.
Thank you so much, Dr. Gillingham. Thank you for your research and your time and your effort in explaining ketones with us. So if you have your question, please feel free to go ahead and raise your hand. I'm gonna ask you a quick question first too.
Sure.
I'm curious with your study, if those patients stayed on MCT or C7 during the study while they were doing the ketones, or if they had to get off of it in order to do the study.
Well, it was an acute study. It was just that one day. So we did not give them MCT or C7 during that one day. So they were off it for that one day. They took their normal diet, normal routine up until that morning that they showed up at the hospital for that one exercise day. And it was just muddied, could we see anything different from ketones, which is why we took them off of it.
So ideally, if this were to become a therapy for FAODs, it might be something they could take with MCT or
potentially. This is interesting because I've just been in conversations with a dietitian about this very subject. One of the ways MCT and C7 works is by raising the ketones. So you want elevated ketones. Ketones obviously have a benefit, but we don't want hyperketosis either. So there is a balance there. If we already have elevated ketones with MCT or C7, as in the 500 to 600 micromolar range, I'm not sure you want to add more ketones on that. For instance, we worry at really, really super high ketone levels with ketoacidosis. Now, that's never ever occurred in a patient with an FAO disorder, but we wouldn't want to induce that by 2 sources of ketones. So I think there's going to need to be some research and balance there. So some ketones good, too much ketones not good.
how do they test those ketones in the
How do they test the ketones?
to see if they reach
The
that
blood?
max?
So you can most clinical labs will run a ketone assay, and then we do it, in our lab with a specific assay as well. So I think it can be a fairly routine thing ordered to get ketones measured.
Okay. Yeah. I'm gonna go here just closer and then, okay.
Hi, thanks so much. Do you know if anyone's looking at using ketones plus amino acids like glutamine in combination to see an effect?
I have not read specific studies on that, but that would be an interesting thing to look at, a ketone with an amino acid supplement. But I haven't seen, and I don't know if anyone's trying to make a product where ketones attached to an amino acid. I don't know the answer to that. An interesting idea, but I haven't read anything specific.
Okay. And do you know how clean the Nestle product is, or also the commercial ketone ester? Did they run it through mass spec? Do they have a comfort level with how clean the product is?
Yes, the product we test had a mass spec analysis, and it was very clean. And in particular, that product, they're really focusing on just getting the D.
Oh, right.
Hydroxybutyrate. So they had to do the mass spec to make sure that they had separated the isomers and only gotten the D.
And do they expect that if you were to do like 4 times a day dosing, in addition to doing it for like a month or 2, is there a hypothesis that you would see improvements in that exercise tolerance?
Yes, I can tell you that's definitely where Nestle wants to go, a 4 times a day longer trial to see what we see. But yes, I think that's the concept.
Okay.
And the first paper I presented in MADD, that was 4 times a day for years. So it was a much longer thing. You're not going to see an improvement in cardiomyopathy with an acute one dose
Sure. Yeah.
supplement. So you're going to need to do a longer term dosing to be able to see that kind of difference.
All right. Thanks so much.
Yeah.
Do you think a study like that would be open to the FAOD community with Nestle?
Oh, that's what Nestle is proposing. Yes, is open to the FAOD to specifically test it in FAODs. Yes.
Originally, I had two questions. I think one of them was answered in terms of the hyperketosis and the MCT. It was going to be, could the ketones eventually replace or at least replace some of the MCT?
I think that's possible. I mean, I think you could down the dose of MCT and replace it with ketones. But keeping in mind that one of the ways MCT and C7 works is it's converted to ketones. It has other effects too. That is not the sole route in which MCT and C7 works, but it does raise your ketones. We've done it enough times to know that MCT will raise ketones in patients with long chain FAOs.
Okay, and then the other one is, how does that compare to the Reneo study? Because there was a similar experience with the Reneo of doing the repeat treadmill tests and having less, respiratory issues and stuff in the second treadmill
Gotcha.
test. How does that compare?
So that drug is a very different drug. So its idea is to increase your muscle's capacity to do fat oxidation, right? So it's not impacting the liver converting a substrate to ketones. It's increasing the muscle's ability to burn fat. So it's a completely different approach.
But hypothetically, you could use both for treatment.
Hypothetically, yes, you could use both. Yeah.
Okay, cool. Thank you.
Yeah.
Thank you. So we know that MCT improves or increases the ketones. Is it possible that even on tons of MCT, I mean, my son's on MCT oil, Pro-Cal, and the Lipostarlica formula, is it possible that it couldn't, maybe it's not working and to increase the ketones enough that he's, if he's still experiencing some of those things, like, is that a possibility? And
That's a good question. So let me back up and try to address it a couple different ways. So first of all, ketone supplements is an interesting therapy. Do I think that ketones are going to solve all problems of FAOs? No,
Okay.
It is not going to make everything go away, like all the rhabdo, all this is problems. This is another addition to the toolkit, but it's not the answer. At really high doses of MCT, if he's, fasting, then those ketones are going up. Would a ketone supplement above that be helpful? I think those are questions that are all up for research and we just don't know.
okay. Okay. And then, so the 4 types that you showed at the beginning of your presentation, does the efficacy of either of those depend on the person? Like, do the esters work better for this type of patient than the other salts? Or are they all pretty similar in effectiveness?
That's a great question. And the only way to really answer that question is to look at the studies at how high they raise the blood ketones, because we're looking for that ketosis level of 500 micromolar or 0.5 millimolar. And I would say both products do the same.
Okay.
So it's not necessarily related to the person. The
Okay.
timing might be slightly different, like how fast after you take it does it raise it?
happens.
And I can't remember if I've seen a time course. Does it take a little bit longer for the ester to reach its peak? I don't know the answer to that.
Okay, gotcha. Thank you.
Okay, we're gonna take one more question.
My question is, what is the end goal in taking it in CAD, for example?
Well, so with MCAD, when you can't make ketones, the idea is to replace something that would normally be there when you exercise or when you maybe didn't eat as regularly as you wanted to, and would that prevent any sort of symptoms down the line? So it's replacing something that would normally go up if you exercised, but doesn't because you can't do fat oxidation in the liver. So you're right. What is the end goal? We would have to just, I think, do the study to see, but it would work in MCAD as well. So no, it's a good question.